Hello, everyone, and thank you so much for joining us for our webinar today. Welcome to Taboo Topics in Parkinson's Disease, a monthly webinar series where we explore topics with stigma attached to them and try to normalize the conversation. My name is Maggie Ivensey, and I am the Center Coordinator at UNC-Chapel Hill's Parkinson's Foundation Center of Excellence and Cure PSP Center of Care. And I'm so glad that you've been able to join us today or are streaming this video at a later time. Before we get started, we do have a couple of housekeeping items to remind you of. All participants are muted during this webinar, but we encourage you to use the chat feature to ask any questions that you have. And note that our presentation and speakers' responses to questions are not meant to serve as medical advice, but keep that in mind, and we recommend that you do not share any personal health information in the chat. We encourage you to talk to your own healthcare teams about specific medical concerns and questions. But with that being said, our topic today is sex and intimacy in Parkinson's disease, and our presenters are Dr. Daniel Roque, and a movement disorder specialist here at UNC-Chapel Hill, and Lisette McEwen, a pelvic floor physical therapist at our UNC's Rehab Center. So thank you both for being with us today and for sharing your expertise. Dr. Roque, I'd love for you to start us off and sharing about some research.
Sounds great. Can you hear me?
Yes.
Okay, fantastic. Let me attempt to share my screen and hope that that works. Are you able to see, maybe more specifically, able to see my presentation now? Okay, fantastic. All right, everyone. Pleasure. Daniel Roque. I've been at UNC now going on 13 years, working with the Department of Neurology and the Movement Disorder Center. And here I am hoping to talk to you guys today about some work that we did back around 2017 for the better part of a year or two, collecting information we felt was needed, very sorely needed, information that just didn't really exist in the format that we collected it, to see if this might spark some interest in making a dent on this taboo topic, which absolutely it is, in just discussing sexual health with providers, or honestly, even with your partner for that matter. And certainly this was a focus on folks who do have Parkinson's disease. But the hope would also be that as we continue to study this work, that maybe we can extrapolate this to other movement disorders as well. There we are. Okay, so a quick overview of what we're going to do today. We'll start off by presenting the case for why it is important to study sexual health in Parkinson's disease, then follow that up with a review of how we set up this study that I'll talk to you about for a few. Look at those outcomes of the study, and then discuss possible implications of the results of the study and maybe some considerations for you or your partner's sexual health. So let's start off with this idea: why should we be concerned about sexual health in Parkinson's? Well, let's start with something relatively commonplace and understood by most, which is that we certainly in Parkinson's, or persons with Parkinson's, already are coping with some difficulties with motor skills and overall movement, speed of movement, or even range of motion in that process, in addition to a number of what we term non-motor symptoms, so things that are outside of the stiffness and the slow movement, but very much get categorized in the symptoms of Parkinson's disease. When you look at those non-motor symptoms, we actually do, they are ranked, and they're ranked based on how often they're reported by patients in larger databases. And what we've learned is that sexual dysfunction actually ranks right in the middle in terms of the most bothersome, not even necessarily the most frequent, but the most bothersome symptoms within those non-motor symptoms of Parkinson's disease. What's tough to parse out, at least historically, from this information is that certainly you're allowed, as we get older, to develop additional medical issues that do impact sexual health. Some easy ones that come to mind are high blood pressure, medication side effects. But that's just adding insult on injury. So we're trying to parse out and understand a little bit better how this is impacting folks, and moreover, is there anything we can do about it, right? Because this means this is quite bothersome in the grand scheme of things. Just to add insult to injury here is that physicians don't regularly engage in discussions of sexual health unless they're subspecialists or particularly trained or interested in the area. Some of this has to do with time. Some of this has to do with general comfort levels with those providers. Care partners, as we refer to folks in the field, are often also sexual partners. And so sexual health for a person with Parkinson's has greater implications outside of that person, and just having that that sense of bonding between one person or another. And treatment options could include medication. So certainly this is an option for some providers to be able to help through prescriptions, but really counseling may actually provide more useful, or at least in combination, more useful outcomes for folks, like meaningful outcomes, changes, improvements that you might be looking for. But they're not necessarily commonly available, meaning that those counseling sessions or therapists may not necessarily be readily available in your community. And they may not even be covered by insurance, which is certainly something we would desire if it was at all possible. So knowing this preliminary information, we went ahead and put this effort forth in 2017, 2018. We were trying to study a little bit more about sexual health in our patients who come to our clinic with Parkinson's disease. We were lucky enough to be able to recruit folks who were in our clinic, just standardly in our clinic, who would come through and who were interested in participating. I appreciate many folks who did, because they were even excited to know that someone was asking them questions in this field. So ultimately, we did recruit 100 folks who had Parkinson's disease. One caveat I don't write in here, but is absolutely the case. I mentioned how there are other health issues and medication side effects that can certainly impact sexual health. So we tried to get about half of folks to basically have no known history of other medical issues that might interfere with sexual health. And then the other 50 folks with Parkinson's were free to have any other additional conditions. And then we were open to having care partners who also identify as sexual partners come and fill out and participate in the study as well. But we're not necessarily expecting as many folks to come, but we were fortunate enough to have just over half of our persons with Parkinson's have their care partners be willing to participate as well, which was honestly much appreciated. What everyone went through sort of in combination here, you see the person with Parkinson's and care partners were both filling out surveys. They were near identical surveys, but questions had to be formatted a little bit differently for each person. We also obtained some medical history for both, although most of the more robust medical history we grabbed from the person with Parkinson's disease, and that included medications and dosing and the like. Every person with Parkinson's had a standard neurological exam, also had a short battery of cognitive testing and thinking testing, so that we can try and make correlations where it might make sense. And all that data was analyzed anonymously. So it was a single survey, just a number. We were trying to make folks feel very comfortable participating in this study. We really couldn't at all link back any of this information back to a single person, given the way we collected the data. So I think that privacy was extremely, extremely important. I think was probably one of the best selling points of participating in the study. So again, much appreciated for those who did participate. And this is what we started finding. So let's start with something that I've been mentioning a few times now, which is, are there additional issues or additional medical issues or medications that might be interfering with sexual function right off the bat? You'll notice that the patient with Parkinson's list is at 50, because as I mentioned earlier, we had 50 patients that, to our knowledge, had no other issues, no other medical conditions, and then we had 50 patients who did. So when you compare these numbers, there was a tendency to have more often than not high blood pressure, but more often than not depression. And these are really significant and important features. The other category seems large, but it's a mix and a hodgepodge of a lot of other conditions. These 6 conditions you see in this table in front of you are often the best or most described conditions that we know come with sexual dysfunction as a frequent symptom. So, depression and high blood pressure being among the highest that we saw there. And it was somewhat similar as well for the care partners, right? Because again, we're grabbing some medical history there that was relevant. Who was the average person with Parkinson's who participated? And again, this is an average because we did have an absolute spread of this. The average person was about 7 years into their disease, at least from their diagnosis year, maybe not from symptom year. 80, just over 80% of folks were on levodopa in some way, shape, or form. And just over 30%, so just over a third of patients were on antidepressants at the time of the survey. The vast majority of folks were married, the vast majority of folks had children, and you'll see here the spread, the gender spread, where we're seeing 67 men participated and 33 women participated in the study. And those were persons with Parkinson's disease. And what were the complaints? So in the persons with Parkinson's disease, the most common reason for stating that they were sexually inactive, for those who stated that they were, was because of their own personal poor health or erectile dysfunction in men. And that there's some global concepts that in the surveys that were given to them to help describe what poor health generally meant. So poor health could be medical or could be poor sexual health, that's big enough to try and be inclusive of multiple complaints. But even for the person with Parkinson's, they felt that in 21% of the cases, partners' poor health was a reason for being sexually inactive. So not as frequently, but nonetheless, that was a factor that played a role. An important thing that came from this was the realization. We asked patients, how often do you feel that your provider asks you about your sexual health? And only about 13% said that providers ever asked them about their sexual health in their routine visits. So, not so eye-shocking to us in the field, but at the same time, it's an important point and one that we're hoping to raise awareness of. So I'll make sure I didn't get too far. I did not. Okay. But here is the spread. So I mentioned how, we allowed for some vagueness, but also we collected information about the more specific complaints when it came to sexual health problems. And notice that there's two sets of bars here. The first set, which are the light blue, this is how they felt in terms of the frequency that they had, lack of desire, lack of pleasure, for men erectile dysfunction, for women vaginal dryness, before their diagnosis of Parkinson's. And then those same patients are answering, that's based off of memory, of course, how they feel that change has occurred after their diagnosis of Parkinson's, right? How frequently they're experiencing that. And in just about all cases, what you'll see is, with a couple of exceptions of vaginal dryness and pain and early climax, other factors, other descriptors of sexual dysfunction were quite discrepant, certainly present to some degree, but not very frequently and prior to the disease, but they feel much more prevalent, much more of an issue now that they've had the disease and as their disease has progressed. So quite a few of them appear very discrepant, but at least there's, again, that consistency across multiple factors, not just one. How about perceptions or changes in perceptions between persons with Parkinson's disease and their care partners? Men with Parkinson's were more likely to perceive erectile dysfunction as an issue that they were experiencing as compared to men without Parkinson's who were care partners. For the persons with Parkinson's, they felt less attractive. They're more likely to feel less attractive as compared to the way their care partners perceive them in terms of feeling or not feeling attracted to them. And motor symptoms across both patients with Parkinson's and their care partners, motor symptoms were not infrequently quoted as a contributing factor to why they felt that they were less sexually active. But that was similar between the two groups. So that was not a different perception there. And you can see some of this labeled here. You see the blues are the men and the pinks here are the women. What we're trying to show is a person with Parkinson compared to their care partner, and again, person with Parkinson compared to their care partner. That discrepancy between men with Parkinson's and men without, meaning the care partners, you see kind of between those two blue bars, but largely not nearly as many differences between care partners who are female and persons with Parkinson's who are female in terms of their sexual dysfunction and their reports therein. And these are specific, the scales we're talking about here are not just regular questions. These are sexual function scales. For women, it's referred to as the Female Sexual Function Index, and for men, the International Index of Erectile Function. So these were specific surveys that have been validated outside of Parkinson's disease, that we just wanted to get an understanding, is there anything clearly different between these groups? And what about seeking services, which is the other topic I mentioned earlier, an important one for our patients. So persons with Parkinson's were more likely to comment that they felt comfortable asking their own care team members, their clinicians, their primary care physicians, their neurologists, for advice regarding their sexual health more frequently than their care partners would. But both care partners and persons with Parkinson's disease were open to seeking out consultation with a sex therapist or a group sex therapy session to learn opportunities, to improve their sexual health. So that was inherently reassuring, and that was actually true with or without insurance coverage, which is another factor we put into the survey. But certainly, if it was covered by insurance, folks were a bit more likely, but that was pretty equally the case. And here's some of that spread. You'll see the blue refers to the person with Parkinson's, the gray refers to their care partner, and you just see like what is the likelihood you use services. The medical doctor, as I mentioned earlier, persons with Parkinson's more frequently would feel comfortable making that request. But you'll see that generally all these numbers are roughly between 15 and 30% on the whole, not if per group, not if you collect both person and their care partner, because that starts to grow significantly higher. But it means that at a minimum, there is a group out there, even if it's just a third of persons, who do feel like there's an opportunity for them. So maybe what can we learn from this to wrap this section up? Sexual health concerns, they are definitely commonplace in Parkinson's. There is this greater tendency for erectile dysfunction identified in men with Parkinson's, even in the absence of other conditions that might cause erectile dysfunction or sexual dysfunction on the whole. But the point here would be that there are other issues, other identified factors that can impact sexual dysfunction. So talking with your providers, different providers, or even therapists, sex therapists are very well versed in items like variables that can impact your sexual health. So either way, just getting an understanding and being comprehensive with your review of your own medical history so that they're not missing any variables that they could help impact in a positive way for you. Past this, there is a desire by roughly a third of persons with Parkinson's, like I mentioned, to try and improve their sexual health in some way, shape, or form, either with the help of their current care team or maybe employing the help of a therapist or group therapy. But really, care team members rarely raise the issues. So at a minimum, get started with your care team and speak up for your sexual health. That's going to be an important point, I hope, coming out of this. Past that, care partners also want to help their spouses. And honestly, frequently are willing and wanting to find those solutions. We see that in the lack of discrepancy between wanting to seek consultation. So I'm going to use this as a statement of be open and willing to talk to your partner about your sexual health and about your sort of commonplace sexual health and relationship. Hopefully you feel like you're in a good, safe environment to do so. And through that effort, speak up. It's sort of hoping you're seeing that common theme of speak up. All right, so that's that, and I think I finished with maybe a few minutes over, but Maggie, did you want to leave time for questions later, or?
Well, if anyone has any specific questions about the data now, I didn't see anything come through the chat, but we can take a pause for just a minute or so to see if anyone had any specific questions about the data or the information that you shared. And then we'll move into Lisette's presentation.
Perfect.
But thank you so much for sharing that data. It is very exciting that we have this information and gives us good insight into how to care for people.
Yeah, agreed.
Well, if there are questions coming in, I think that Lisette might be able to answer them throughout her presentation, or we might come back to it. So Lisette, welcome you to take over.
Great, thank you. Thanks for everybody for coming. So just a little bit about my background. So I am a pelvic health physical therapist. So I have training. Pelvic health physical therapists are trained specifically. We go through regular training for physical therapy, and then we take specialty courses to familiarize ourselves not only with the anatomy of the pelvis, just becoming more and more familiar with that, but also things like being able to have discussions about sex and intimacy, urinary continence, bowel function, all those kinds of things are all within our wheelhouse. So I try to create an environment, and so do all my colleagues, of very open discussions. So what I thought we'd start with is, yes, I'm glad that somebody didn't know that they're a pelvic health physical therapist. That's very common, so that's great. So I'm going to start with just kind of showing the models here. I find it easier to look at the 3D model even on a WebEx, so rather than just a flat picture. So I'm going to show both a female pelvis and a male pelvis, just so you can start to see kind of what the anatomy looks like. So I'm going to grab my female pelvis here, and I know it's not perfect by WebEx, but we can at least get an idea. So I'm going to tip it up here, and what we're looking at is above, as if the camera was coming from my head down. And we're looking at the front here. This is the bladder, and this is the uterus. So I'm going to flip from underneath, and this is looking below. So vaginal opening here, around the anus here, and all of these are the muscles of the pelvic floor. So when people talk about pelvic floor muscles, they're talking about the floor of their house. So if you're looking from below here, the pelvic floor has multiple functions. It has a function of support. Because it's the bony ring, there's nothing there. So the muscles work hard to kind of keep the organs up there, like your bladder and uterus. For men, they also have their bladder and all of the sexual organs for males as well, which we'll go over in just a minute. It has the function of keeping the tubes closed so we don't leak urine or leak stool. It has a stability function, so it works along with the stomach muscles, the abdominal wall, as well as the back muscles to help keep us upright. And then it has a sexual function, which we're going to kind of spend more time on today. So that's what the female pelvis looks like. I'm going to grab my male pelvis. The muscles of the male pelvis are the same, except for the sexual organs. So looking from above, there's the bladder, my penis, and then if you look from underneath, again, there's around the anus, and these are all the muscles of the pelvic floor for males. So when we're looking at Parkinson's disease and things that can be happening with sexual intercourse and function, we know from Parkinson's disease, one of the things that we see is a lot of rigidity in the muscles, and that can, or lack of movement, and that can also cause weakness over time. So some of the things when people talk about diminished sexual function, they're talking about there can be a difficulty with, we talk about erectile dysfunction in erectile dysfunction in men, and vaginal dryness in women. So one of the things that we do for our male patients is we try to work on some strengthening of the pelvic floor muscles. And people think about, oh, strengthening is for to decrease urine, those type of things. But also we think about trying to move the pelvic floor, because when we think about rigidity in Parkinson's, when the pelvic floor is not moving well and gets tight, it actually can mimic as if it's weak. So for instance, if I was holding my bicep here all day and then I tried to use my bicep, it would appear that it was weak, but actually it's just shortened. So one of the exercises that I'm going to teach you today, right now, is something that you can start doing in general that can help your pelvic floor, not only for sexual function, but also for bowel and bladder function, is breathing. And people learn breathing for all kinds of different reasons. But the reason why we teach it a lot in pelvic health is as you take a breath in and the muscle underneath the rib cage, your diaphragm, drops down, and then you take a breath out and it lifts up, the pelvic floor acts like a sump pump and moves with it. So one of the most simple things you can start to do for sexual function is to take a deep breath in through your nose and out through your mouth. Thinking about your rib cage expanding like bird wings when you take a breath in, and closing like bird wings when you take a breath out. And we can start to help that rigidity in the pelvic floor over time with getting the movement. For women, when we talk about the vaginal dryness, again, it can go back all the way to rigidity. What helps keep the fluids flowing within the vagina is the pelvic floor movement and getting those glands to help secrete fluids. So one of the reasons for vaginal dryness, there can be many. It can be hormone related. It can be history of other medications. It can be all kinds of things. But one of the things that we can help is by getting the pelvic floor moving, we can actually help get some increased secretions for vaginal dryness. Another kind of handy tip to use that many women are not, and they're not asked about it as much as Dr. Roque was saying earlier, is about vaginal dryness. Is there's a lot of products on the market, and I would be sure to speak with your healthcare providers before using something, but there are different products on the market. I just have a couple things here that are vaginal moisturizers that can be used. We think about putting lotion on our skin. There are specific products that can be used for vaginal dryness that are, you can use things as simple as coconut oil. Again, make sure it's clear that there's no reasons for infections or things like that, but you can use coconut oil on a daily basis just at the vaginal opening to help create some decrease in dryness. There's a product on the market, and I'm not endorsing any products, but there's many things out there. But one that's on the market is called Replen's Long Lasting, and it's something that you can use every other day to kind of help the tissue. So for women who are experiencing vaginal dryness, which then can lead to pain. It's when there's dryness of the tissue, it's no different than if your skin is really dry. It can create problems with the vaginal dryness. One of the big things, and it was brought up in the study, is that we see in our discussions with patients here, and I have the great opportunity of being able to, when I speak with patients in the clinics that we work with, of being most of the time having both partners here. So having the patient and their partner here. And that's a really great opportunity for us to make it okay about speaking with your partner. That is one of the best things that we can do as far as with sexual intimacy, is opening that door to discussion. So being okay with having communication and discussing where you are as far as it needs being met, those type of things. I used to present quite a bit, and we do work pretty closely with sexual therapists here in pelvic health. They have such a big role. So I am personally a big fan of including them as part of your care team because they just present so much knowledge. And when I used to work with a previous sexual therapist back in a different state, one of the things that has stuck with me is she was talking about, if something is important and a priority to you, is setting time aside for it. So having that discussion where it's not just a spontaneous thing that happens, but maybe it becomes something that becomes a bit of a calendar date and something that you prioritize by putting it on the calendar. And while some people say, oh, it's not spontaneous, it's not as fun, it doesn't lead towards sexual function, it actually can make a big difference, and it can actually make people look forward to something and know that they have this time that's set aside for this activity. Good for some Parkinson's patients, they tend to have more rigidity in the morning. Not everyone, but for some people, in the afternoon, later in the day, as they get fatigued, they have more rigidity. So maybe that time that you set aside is more in the mornings, in the AM. So it's really having those discussions with your partner as to and making that okay and putting it out there so that you can have the discussions whether this is something that might work for you, is scheduling it into your day or into your calendar to set aside time. Along with that is thinking about what does what does that look like to you? And maybe setting different goals. So one thing that we know is certain positions can be difficult or unable to do. And I'm talking about like even maybe lying flat on the back or those kind of things, even functional positions. So that's one thing to kind of talk about is, are there more comfortable positions to lie in? Not even for sexual intercourse, but just for intimacy and talking. Are you more comfortable sitting in chairs? Are you more comfortable lying down? So having all of those open discussions that way. Let's see. Let me go where I want to go. I wanted to give you some exercises that are things we want to get when we're talking about strengthening or getting things moving. We have a lot of success with erectile dysfunction with doing some strengthening of the pelvic floor as well and getting the blood flow. That's the other thing that happens is as you use these muscles. So I wanted to show you a couple simple exercises that may or may not work for you that you can start doing that we teach often in here in pelvic health. So I'm going to grab a ball here and I'm going to bend my camera down. So with the pelvic floor muscles, when you have pelvic floor muscle weakness, sometimes it's hard to kind of feel those muscles contract and relax. So we can use other muscles like the muscles around your hip to help stimulate the pelvic floor muscles. This is actually, there's more and more research out there. Early on, there was not a lot of research in pelvic health in the world of physical therapy and muscles at all. It's still fairly slim. It is getting much better. But this is actually a researched exercise that does show overlap into the pelvic floor to work on strengthening. Overflow, excuse me. So what you can do is take a ball or roll a towel and put it between your knees. Press down a little bit. And you can squeeze your knees together and you'll feel the muscles in between your legs contract, and that will help contract the pelvic floor. So what I'm doing is holding for about a 10-second hold, 5 to 10 seconds, depending on how it goes for you, and then relaxing for 5 to 10 seconds. And you can do maybe 10 or 20 of those once a day. It's not about going as hard as you can. It's about contracting the muscle, holding for 10 seconds, and relaxing the muscles and relaxing for about 10 seconds. So that's a simple exercise to add into your day that can really help create strength for the pelvic floor. One of the other things that we know with sexual health, with Parkinson's and some things that help, and actually not just sexual health, but in general, is that you can have, with the rigidity, it can also be facial rigidity. And one thing that I've definitely heard from my patients over time is that they see when they're looking at their partner, they don't see the same facial expressions. And so that can be misread as a lack of desire when actually it's really just facial structure. And facial rigidity. So that's another thing that goes back to the communications, is having that to know. Yes, I just saw in the chat. Yes. Yeah, that's a big one that comes up a lot in a lot of research studies, that that people think that there's a lack of desire because of those lack of facial you know what I mean, word finding problems. So that's something to talk about. There was the big one that comes up for both men and women is a lack of climax with orgasm. And there's sometimes strength can make a difference for that, but there's sometimes where it's the nervous system involvement as well. So I think the other big piece to talk about with your partner is, what is the desire and the outcome for sexual activity? What does that look like? Because sometimes resetting goals and expectations of outcomes can be really helpful in communication. One of the big things about intimacy is intimacy can be well-being for both emotional and physical. So that may look different as far as what intimacy and touching looks like versus being able to, that a lack of climax does not mean that sexual activity was not successful. So kind of defining what that looks like for you and your partner can be really helpful. Just gonna big things. The big thing that I wanted to go back for was for when talking about the depression, and I did see that the number of 40% come up quite a bit as for patients with Parkinson's. Have several research studies that came up that 40% people self-describe them as symptoms of depression. With that lack of sexual desire, there's that question of how much is coming from the Parkinson's, and how much is coming from the lack of sexual activity that adds into depression. There's also, as we know, some medications that are used for depression can definitely decrease libido. So you have a low libido or sexual desire. And so it really is important to talk to your care team about these experiences that you're having, and do advocate for yourself. As was in the study, it's disappointing to see that only 13% of providers ask that question, but it's not surprising from what we hear in our clinic here as far as that happening. Another thing that can really come up is fatigue for people, and so a lack of wanting to participate in sexual activities because of fatigue. And so one of the things we encourage is being able to do, when people think about exercise, taking exercise at smaller increments than maybe you're thinking. So when I ask patients if they walk for exercise, many people will say no, but they'll maybe walk to their mailbox and back. And so, when I actually start trying to see how much they're moving, sometimes in little ways throughout the day, we can increase our activity. And with that increase in activity, being mindful of not going so far that you end up with a lot more fatigue is slowly building the endurance. And that, like I said, that can look like going to and from the mailbox. That can look like parking literally 4 or 5 spots further away if you are mobile, and just walking that extra bit if you're going into stores. It can be doing as simple as doing a few extra sit to stands as you get up. So each time you get up, maybe you get up twice instead of just getting up once. So there's small ways that you can build increased activity into your day that over time may help with the fatigue. Those are kind of the big things that I wanted to make sure. I wanted to make sure we left plenty of time for questions, because I'm really hoping that people will, with questions that will spur some further discussions. So that's my spiel.
Thank you, Lisa. Thank you for sharing that. And we will leave some time for questions to be added to the chat. But I have one to start us off with. Lisa, what would you say is like a common misconception that people come to you with? What do you think?
Sure. I would say the biggest one is that sexual function automatically declines with age. So outside of any medical condition, that sexual function automatically declines with age, and that lower libido or sexual desire is normal as you age. And that is not normal as you age. Everyone comes in with different abilities and different desires, even from a young age, but it is not automatic that with aging, people have less desire and don't want to be intimate. It was actually recently at a symposium, a pelvic health symposium, and was working with one of the oncology NPs, and out of totally different medical condition, but what the same thing came up. And what she said is so many of her own colleagues have had this assumption that people don't want to be sexually active as they age, and that is not what we see. When you ask people, when you ask the questions, the doors open and people will say, well, actually, yeah, I'm kind of not so happy about that. That kind of bumps me out. But they just assume, both from providers and from patients that we see, that's just kind of normal in aging. So it does not have to be.
A super great answer, and kind of calls back to that 13% of providers even asking about it, because if you don't ask, you don't know, right? Yeah, yeah, we're all under that assumption.
Very true.
Let's see. And when would you recommend reaching out to a pelvic floor physical therapist? Like, what would be going on in your life that you would say, maybe that would be helpful for me to have a referral?
Yeah, so I would say there's lots of things. I mean, urinary incontinence, urinary frequency, urgency, any kind of constipation, which is another big one that we see with Parkinson's, right? So people who have constipation issues or difficulty with bowel movements, definitely with we can certainly, with sexual function, we certainly are always open to those referrals as well. But any bowel, bladder issues, any pelvic pain, and that can include even when we think about not even just the base of the pelvis, not even the pelvic floor muscles, but when we're talking lower abdominal wall or pelvic ring pain, any of those kind of things are things that we as pelvic health therapists see. I noticed that in the chat, I was just pulling up that when we were talking about facial rigidity, that Kate had put in, it's not just desire, but it's all emotions for lack of facial expressions. And yes, that's very true. Thank you for bringing that up. It's not just about desire. It can be happiness. It can be sadness. It can be all types of emotions. That's very true.
Yeah, and that can cause tension within relationships, and confusion within communication, and can make that intimacy awkward, or even just hard to initiate, because all of the nonverbal cues that we're used to kind of perceiving are different. And so sometimes I think, and you mentioned this, Lisa, just asking the question, or scheduling a time so that it's on everybody's mind, and it's something that you can look forward to, instead of having that anticipation of, is it going to happen, or is it not going to happen? Yeah.
And the pressure of that too, right? That's the who initiates, who thought, are you going to be that? So all of that kind of thing can be, if you're scheduling a time, then everybody's on the same page. And along with that, as far as when you're having those open discussions, there are so many resources out there of, books that you can do with open-ended questions that you can fill out things together. So I don't want people to feel pressured that if we're going to sit down and we're going to have this intense discussion about sex and intimacy, and somebody has to come prepared as if it's a lecture or anything like that. There's lots of different resources of like, hey, let's do this fun, fill out this fun book. And it's like, okay, what would a date look like to you? Or creating those kind of opportunities or for your partner, and showing those kind of things so you don't feel so much pressure in having those discussions, that you have something to help you lead those discussions maybe.
Definitely. And if anyone's feeling shy about asking a question, because I'm not seeing many come up in the chat, you can ask me directly. You can choose who you send the message to. You can send one to me directly. That way it doesn't show up in front of everyone. We can keep everything anonymous. But know that the question that you have, likely everybody who's on this call, or everybody who is going to be listening to this presentation later, also has that question. So encourage you to think about what you would like to know. We've got two very good people to answer these questions today. So I've got another one while we're waiting for a couple more questions, but no, you can send them to me anonymously if you would like. Another thing that came up for me as I was listening is
Maggie, if you want to think about that, while I want to make one other quick
sure.
comment about emotions and romance. One thing that similar taboo topics and that similarly shows up in Parkinson's as another non-motor symptom. It's actually more bothersome for care partners and for patients, but plays very much into this commentary is the fact that you can develop mood disturbances, right? You can develop depression and anxiety completely separate and irrespective of any motivating factor to become depressed or anxious, right? Parkinson's absolutely comes with an increased risk of having these conditions for no good reason. It's part of the condition. Separating that is important. In fact, interestingly, it's perhaps even more responsive to antidepressants and anti-anxiety medications than a more traditional approach for unrelated to Parkinson's, anxieties, and depression. So it can be a little tougher for folks who come into the disease already with depression and anxiety, but for those who develop it along the way, sometimes just starting on medication can make a big dent. Other times, starting with a counselor can make a really big dent too. So all that said, not ignoring that as a separate treatment pathway to a successful actual sexual relationship, because these are really, really good points. And sometimes there are some exclusive components for one symptom versus the other, versus in terms of management. So don't ignore that. Don't ignore that possibility.
Yes, thank you for adding that. I definitely a big advocate for therapy, and that it could be a good place to start. Sometimes having that non-judgmental third-party person who's not involved in the relationship can be a really good objective person to kind of bring these emotions, these desires, to them, to say, this isn't happening for me, or I would like it to happen in this way, and to talk about strategies on how to make those improvements. So for sure, another good place to start. So, and both of you have touched on this, that there is not there's not one solution for everybody, right? This is can be tailored specifically to what your needs are and who can help you. But like Dr. Roque said, the start of it is is speaking up and advocating for yourself, and saying what your desires would be. The other question was, and it's a little different than misconception, but what's the most common challenge that people come to you related to sexual health, Lisette? What would that be?
So I would say a lot of our male patients, their biggest complaint is erectile dysfunction. We see that a lot in our clinic, and so like Dr. Roque said, there are some medications. Sometimes medications can be helpful, so talking to your healthcare providers about that. The other thing that kind of gets a bad rap, but that we talk about here in public health physical therapy, is penile pumps. That they can be really effective for some of this population. So there are certain ones that we recommend. So that's one of the things that is so there's not systemic medication, but sometimes penile pumps or tension rings, which can help hold the blood flow in the penis when it is erect, can be helpful. So those are some things to kind of consider as well. But that's probably one of the biggest things, that the biggest challenges is definitely the erectile dysfunction for males and vaginal dryness for females. And again, in the chat, the whole thing of partners taking care of their sexual health as well. So if you have the male partner in the relationship, if it's a female-male relationship, if the male partner is the one who has been diagnosed with Parkinson's and the female partner is having vaginal dryness for whole separate issues with hormone related. So sometimes it is taking care of sexual health for both partners. But that would be the kind of the two biggest bang things that come in as far as complaints of dysfunction.
Thank you. And I think the big thing to know is that it can be treated, right? There's something that you can do about it. You don't have to live with it.
Mm-hmm. Yes, very true. And the other thing that I will say is a complaint that we see a lot is because of urinary dysfunction, like urinary incontinence or urinary urgency, and that kind of embarrassment of those type things definitely bleeds over into intimacy and sexual desire. We see a lot of patients who have to use pads or things like that, and they don't. It bleeds into that them not wanting to talk about that or being embarrassed by that. So the open lines of communication with your partner really can come in, and with your care providers, letting them know what's going on there too. Because a lot of times women will come in, and men too actually will come in, and they've had urinary leakage for a long time, but until it gets really bad, they won't seek help.
Yeah, that embarrassment can really overshadow a lot of issues. And it reminded me, one of the takeaways I had from the research that you shared, Dr. Roque, was that a significant number of people with Parkinson's expressed that they felt less attractive. And I think that's just something that we don't talk about a lot, about that changing of feelings like within a relationship, and it is maybe something that you don't express to your partner, but was a significant thing that we found in that information, and that's going to affect this role of intimacy and sexuality as well. All right. I know that doesn't look like we're getting any more questions in the chat. Let me see if there's anything else on my list. I appreciated you sharing about redefining what intimacy looks like. I think we all have such high, or we can have high standards of what intimacy is supposed to look like through our, blockbuster films and the things that we read in our romance novels or anything like that, and just like redefining, what intimacy looks like holding your partner's hand, and having that time together. Those little forms of intimacy can be big, and because I don't want to say that that's small, that's a big thing, and just making that new definition in your mind of what that looks like.
Yeah, I had read something not too long ago, and I'm not going to remember where it came from, honestly, but that was talking about the difference that little comments can make within a relationship, and that feeling of intimacy with your partner. And it's like those little compliments through the day. And it was talking about that, how that can create intimacy in a relationship just by noticing the small things that then translates into later on, and those positive feelings. So when people are feeling lack of self-esteem because of either the diagnosis or care partners being overburdened, just those moments it was said that it can make a big difference, and that kind of resonated with me. The one thing that I forgot to talk about that I just wanted to jump in on that I had left out was I talked about some vaginal dryness products and things like that. But the other thing that I wanted to put out there is that is the use of lubricants with penetration, and that there are multiple types, and that is a very unspoken, talk about taboo topic, even in our, it's getting people to talk about are they using lubricants and what are they using, because there's multiple types. There's water-based lubricants, which wash off. There's silicone-based lubricants, which basically coat the skin and make very little friction. And sometimes even when a male partner is having trouble with erectile dysfunction, sometimes using good, proper lubricants can actually help maintain the erection. And it certainly can help with partners that are having pain. So, that's a good question to ask, and things to ask your providers. And if they don't know, then finding someone who can get that help, because it's a very underutilized, and people are embarrassed to buy lubricants, those kind of things. But they can make a really big difference for multiple, not just for the actual amount of fluid, but also for erectile dysfunction and vaginal dryness.
Thank you. Yes, thank you for mentioning that. That's super important thing to share, and that there is no embarrassment for needing that to make a good, pleasant experience. So yes, thank you for including that. Yeah, I think that I don't think I see any more things coming through the chat. So I really appreciate everybody joining us today. This was definitely one of our highest registered topics. So I know that it's a topic of interest for many, many people. And I appreciate both of you taking the time to share about your expertise and the work that you have done around sexual health and people with Parkinson's. So thank you for joining us today. And I hope that all of you who are registered will be able to join us for our last topic in this series, which is going to be March 16th. We are going to be talking about spirituality in Parkinson's disease. Bailey Brislin, our palliative care chaplain with UNC, is going to be coming and sharing about that. So thank you, everyone. Thank you for taking the time, and have a good weekend.
Yeah.
Thank you.